Imagine a perfectly healthy 18-year-old girl sitting in an emergency room.
Right, just a totally normal teenager on the outside.
Exactly. Her vitals are stable, but she is just doubled over in agonizing, cyclical, lower abdominal pain.
Oh, that's terrifying for her.
Yeah, and to look at her, she's entirely healthy. I mean, she's gone through a normal puberty, her hormones are cycling perfectly, and her ovaries are doing exactly what they should.
But there's a catch, right?
Right. She is terrified, and so are her parents, because she has never, ever had a menstrual period.
Wow. That's definitely an automatic red flag in the ER.
It is. So the emergency physician brings in an ultrasound machine, places the probe on her lower abdomen, and finds something astonishing.
A dramatic, medical-style animation starts with a beating heart and a clock ticking, then morphs into a pelvic ultrasound image showing a large, trapped fluid collection, hematocolpos, building an immediate sense of clinical mystery.
Let me guess, a massive, dark collection of fluid trapped inside her pelvis.
You got it. Her body has actually been menstruating for months, maybe even years, but the blood has absolutely nowhere to go.
Because of an anatomical block.
Yeah, a microscopic, paper-thin layer of tissue. An imperforate hymen. It's created this complete anatomical dam.
That is just wild. The body is doing everything right, but the plumbing is just blocked.
Exactly. And that brings us to what we're doing today. Welcome to today's deep dive. We are not just, reading through a textbook today.
No, definitely not. We are really tearing down the intricate plumbing, the delicate wiring, and the microscopic hormonal relays of the human reproductive system.
Right. This deep dive is designed specifically for you, the medical student, the resident on your OB/GYN rotation, or really any healthcare learner who needs to master the complex pathology and endocrinology of amenorrhea.
Because it is complex, there's a lot of moving parts.
So many moving parts. Our mission today is to break this down into clear, mechanical, undeniable logic. No rote memorization, no guessing.
By the time we are done today, you will understand the why and the how behind every missing period, and you'll be ready to diagnose with confidence.
I love that. So let's start with the absolute baseline. What is amenorrhea, mechanically speaking?
Well, mechanically, amenorrhea is simply the absence of menstruation. But in clinical practice, it is not a diagnosis in itself. It's a profound clinical symptom.
It's like the check engine light on a car.
Exactly. It is the body's alarm bell.
Yeah.
And to evaluate it systematically, the clinical world divides it into two distinct categories based on rigid temporal definitions.
Right. Primary and secondary amenorrhea.
Yes. So primary amenorrhea describes a patient who has never experienced menarche, which is the first menstrual period.
Let me put you in the clinic for a second. That 18-year-old girl we just talked about, she's a clear case.
Oh, absolutely. By 18, the absence of a period is an automatic trigger for a full diagnostic workup.
But what if, say, a mother brings in her 15-year-old daughter who hasn't started her period yet? Are we hitting the panic button then?
Not necessarily, no. And that is a crucial distinction for your clinical practice. You have to evaluate the surrounding biological markers.
Like breast development.
Right. Typically, the first menstrual period occurs about 2 to 2.5 years after the onset of the cellarge, which is that initial breast development.
So there's a built-in timeline we're looking for.
Yeah, and sometimes this entire timeline can be delayed by up to 3 years as a completely normal physiological variation. We call it constitutional delay of puberty.
Oh, right. Like maybe her mom also started her period late, around 16.
Exactly. It might just run in the family.
Okay, so waiting until 18 feels like a really long time if there is an underlying genetic or anatomical roadblock.
Amenorrhea diagnostic criteria. Primary, never menstruated, example by age 15 without secondary sex characteristics, or by 18 with them. Secondary equals 6-month cessation in a previously menstruating patient.
It does.
How do we draw the line between, she's just a late bloomer and we need an MRI right now?
The clinical threshold usually hinges on those secondary sexual characteristics. If she is 15, has absolutely no breast development and no pubic hair,
then we definitely do not wait until she is 18 to start looking for a problem.
Right. The absence of those secondary characteristics tells us that the ovaries are not producing estrogen at all, and that points to a systemic hormonal or genetic failure.
But if she does have normal breast development,
then her body is clearly making estrogen. In that case, We might allow a bit more time for constitutional delay,
Yeah.
but by age 15 or 16, we are still initiating an evaluation.
Just to rule out things like the imperforate hymen we talked about, right?
Exactly. Primarily to rule out those anatomical obstructions or an absent uterus.
Okay, got it. And then we have secondary amenorrhea.
Yes, the second category.
This is the patient who is getting her period. Maybe it was perfectly regular every 28 days, or maybe it was a bit irregular, but now it has completely stopped.
Right. And the strictly defined temporal threshold for secondary amenorrhea is a cessation of periods for greater than 6 months.
6 months is the magic number.
Yes. If a patient misses 1 or 2 periods, we might just monitor her. But once we cross that 6-month mark, it absolutely mandates a systematic pathological workup.
Okay, so we have our definitions. Primary means the engine never started. Secondary means the engine was running and then completely stalled.
I like that analogy.
Thanks. But to understand why an engine stalls, you really have to be a mechanic. You have to know how the engine was built in the first place.
So we need to map out the baseline.
Exactly. Let's map out the hypothalamic pituitary ovarian axis, the HPO axis. I usually think of this system as a biological relay race.
A relay race?
Yeah, like the baton has to be passed perfectly, runner to runner, to get a period. If one runner trips or drops the baton, or if a runner is entirely missing from the track, the race is over. No menstruation.
I think that relay race analogy is the perfect framework. But to elevate it to the level you need for your exams, we have to understand that these runners aren't just passing a baton forward.
What do you mean? Are they talking to each other?
They are constantly shouting backward at each other to adjust their speed. This is the positive and negative feedback loop.
Ah, right. The feedback loops. Those always trip people up.
Let's trace the track.
Yeah.
The starting line is up in the brain, specifically the hypothalamus.
Okay, starting in the brain.
The hypothalamus produces a hormone called gonadotropin-releasing hormone, or GnRH.
And the really wild thing about GnRH is how it's delivered. It's not a steady stream, right? Like it's not a faucet that just turns on.
No, not at all.
It acts more like a metronome. It's released in very distinct, synchronized pulses.
A clean, animated flowchart showing the brain, hypothalamus, pulsing with light. A graph appears next to it showing sharp peaks and valleys of GnRH release, mimicking a heartbeat monitor.
And that pulsatility is arguably the most critical component of the entire axis.
Really? The pulsing is that important?
Absolutely. The hypothalamus releases a pulse of GnRH roughly every 60 to 90 minutes.
Okay.
If you were to give a patient a continuous, non-pulsal intravenous drip of GnRH, the entire system would actually shut down.
Wait, really? Why would it shut down if it's getting more of the hormone?
Because the receptors on the pituitary gland would become completely overwhelmed, they downregulate, effectively becoming deaf to the signal. The pituitary needs that silence between the pulses to reset.
Oh, wow. It's like a car alarm. If it just blares continuously, you eventually tune it out. You need the pulsing to keep paying attention.
That's a great way to put it. So the hypothalamus pulses GnRH, passing the baton to the second runner, which is the anterior pituitary gland.
Okay, runner number 2. And what does the anterior pituitary do once it gets the baton?
It receives that pulsatile GnRH signal and responds by synthesizing and releasing 2 vital gonadotropins, follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH.
FSH and LH, got it.
And then these 2 hormones enter the systemic blood circulation and travel down to the final runners in our relay, the ovaries.
Now, the ovaries receive the FSH and LH, and this is where the magic really happens. The names of these hormones tell you exactly what they do. Right?
They really do.
Yeah, like FSH, follicle-stimulating hormone. It literally stimulates the follicles.
Exactly. At the beginning of the menstrual cycle, the pituitary releases a wave of FSH.
And what does that wave do?
It recruits a cohort of immature follicles inside the ovary, essentially waking them up and saying, all right, one of you is going to ovulate this month.
May the best follicle win.
Right. And as those follicles grow under the influence of FSH, the cells surrounding the microscopic egg, the granulosa cells, begin to manufacture estrogen, specifically estradiol.
Okay, estrogen is entering the chat. And here's where that feedback loop you mentioned kicks in, right?
Yes. As the follicles grow, they pump more and more estradiol into the bloodstream.
So the estrogen level is rising.
And this rising estrogen level travels back up to the brain and shouts at the pituitary, we are growing, you can slow down the FSH now.
So that's negative feedback, turning down the volume.
Exactly. The pituitary drops its FSH production, which creates a highly competitive environment down in the ovary. Only the strongest, most sensitive follicle survives this drop in FSH.
And that one becomes the dominant follicle.
Right, while all the rest undergo atresia, which is programmed cell death.
So we have one dominant follicle pumping out massive amounts of estrogen. And here is one of the most brilliant evolutionary quirks of the human body, in my opinion.
Oh, the flip.
The flip. For the first half of the cycle, estrogen acts as a negative feedback signal. It turns the brain's volume down. But right around day 12 or 13, when estrogen levels hit a critical, massive peak, the system just flips.
It's amazing. Suddenly, instead of suppressing the brain, that massive estrogen spike triggers a massive positive feedback surge.
And that surge is the mid-cycle LH surge, right?
Yes. The pituitary, sensing that critical estrogen threshold, just dumps a massive payload of luteinizing hormone into the blood.
But what does that LH surge actually do?
It is the absolute trigger for ovulation. Once that surge begins, ovulation, the physical rupture of the follicle and release of the egg, will invariably occur within the next 12 to 36 hours.
Boom. Egg released. But the story doesn't end when the egg leaves, does it?
Not at all.
The ruptured follicle that gets left behind in the ovary undergoes this incredible transformation. Thanks to that LH surge, it morphs into a temporary endocrine gland called the corpus luteum.
Which is Latin for yellow body.
The ovary animation zooms in. A follicle ruptures, releasing an egg. The leftover shell quickly turns yellow and begins emitting a new glow, labeled progesterone.
Right. Because it literally fills with yellow, cholesterol-rich lipids. And why does it do that? Because it's about to become a massive steroid factory.
Precisely. The corpus luteum takes that cholesterol and starts churning out massive quantities of progesterone.
Progesterone, progestation.
Exactly. Its entire job is to prepare the uterine lining, the endometrium, for a potential pregnancy.
So if estrogen was acting like the fertilizer, growing and thickening the lining, progesterone acts like the gardener.
I like that. It stabilizes the lining, makes the glands spiral and secrete nutrients, and it stops the cells from multiplying out of control.
Now, for you medical students listening, this right here is a massive high-yield testing point.
Oh, definitely. Pay attention to this.
You need a way to prove that your patient actually ovulated. You can't just ask them if they felt a twinge. You draw their blood on day 21 of their cycle.
And why day 21 specifically?
Because if ovulation happened on day 14, the corpus luteum reaches its absolute peak production of progesterone about a week later. A surge in plasma progesterone specifically on day 21 is the gold standard clinical confirmation that ovulation occurred.
Perfectly said. And if no fertilized egg arrives to implant in the uterus, the corpus luteum has a strict lifespan of about 14 days. It's programmed to die.
So what happens when it dies?
When it undergoes apoptosis, the massive support beams of progesterone and estrogen suddenly collapse. The spiral arteries in the uterine lining spasm.
Right.
The tissue becomes ischemic and the lining sheds.
And that withdrawal bleed is menstruation. The baton was passed perfectly, the runners ran their race, and the cycle resets.
Exactly.
Now, the reason we just spent, 10 minutes diving into the molecular weeds of normal physiology is that every single cause of amenorrhea we are about to discuss is simply a roadblock on this specific track.
Every disease is just an answer to the question, which runner dropped the baton?
So let's dive into the pathology, starting with the heavy hitter, primary amenorrhea.
When a patient presents with primary amenorrhea, the list of potential diagnoses can feel daunting.
Oh, it's a huge list.
But to master this for your boards and your wards, you cannot just memorize a random list. You must group the etiologies logically based on the patient's physical presentation.
Okay, so how do we group them?
We clinically categorize primary amenorrhea into 3 major groups based on physical exam findings. Group 1 is sexually infantile, Group 2 is masculinized, and Group 3 is normally feminized.
Primary amenorrhea categories. 1, sexually infantile, no estrogen. 2, masculinized, excess androgens. 3, normally feminized, anatomical block.
Okay, let's start with Group 1. Sexually infantile, you walk into the exam room and you have a teenage patient who has absolutely no breast development.
Biologically, this means her ovaries have never produced estrogen, the baton never reached the finish line, or maybe the finish line doesn't even exist.
Now, within this group, the absolute first thing you evaluate is the patient's height.
Right. Yes, height is critical here.
Because if you have a patient with short stature and delayed puberty, the neon sign flashing in your head should be Turner syndrome.
Turner syndrome is a profound genetic anomaly. The karyotype is 45,000 XC.
Meaning?
Instead of the normal 46XX female karyotype, this patient is entirely missing one of her X chromosomes.
Wow. Just entirely missing.
Yeah, and to understand the pathology, you have to go back to embryology. In a normal XX fetus, the ovaries require the genetic material from both X chromosomes to develop properly.
So without that second X chromosome, what happens?
The primitive ovaries undergo accelerated apoptosis, or cell death, while the fetus is still in the womb.
Before she's even born.
Yes. By the time a girl with Turner syndrome is born, her ovaries have degenerated into what we call streak gonads, which are basically just non-functional bands of fibrous tissue.
So the ovarian runner is completely missing from the track.
Exactly.
So when this girl reaches the age of puberty, her pituitary must just start screaming. It starts pumping out massive amounts of FSH, trying to wake the ovaries up, like, pass the baton, produce estrogen.
But there is no ovary there to respond.
Right. So if you draw labs on a Turner patient, you will see sky-high FSH and LH levels, but near zero estrogen.
And that lack of estrogen perfectly explains the sexually infantile presentation. No breast tissue, no feminine fat distribution.
But let's talk about the short stature and the other physical features, because they are so heavily tested. Why does missing an X chromosome cause these specific structural defects?
Well, the short stature is directly linked to the loss of a specific gene located on the X chromosome called the SHOX gene.
SHOX gene.
Yeah, the short stature homeobox gene. Without a double dose of the SHOX gene, long bone growth is severely impaired.
Oh, that makes sense. And what about the other features?
The other classic physical phenotype is a webbed neck. This is a fascinating mechanism.
How does that happen?
During fetal development, patients with Turner syndrome often develop a cystic hygroma, which is a severe malformation of the lymphatic system right at the base of the neck.
So the lymph fluid backs up.
Yes, it creates large, fluid-filled cysts. Often these cysts resolve before birth, but they leave behind stretched out excess folds of skin.
And that presents clinically as a webbed neck.
Exactly. You will also see a wide carrying angle of the arms, widely spaced nipples on a broad, shield-like chest, and a low hairline at the back of the neck.
And as a clinician, you cannot just stop at the cosmetic or reproductive issues, right? Turner syndrome comes with life-threatening systemic roadblocks.
Absolutely. You must order an echocardiogram.
What are we looking for on the echo?
You are specifically looking for a coarctation of the aorta, that's a severe narrowing of the major blood vessel leaving the heart, and a bicuspid aortic valve, where the valve only has 2 leaflets instead of 3.
You also ultrasound the kidneys, right?
Yes, to look for a horseshoe kidney, where the 2 kidneys fuse together across the midline during development. Plus, these patients have a high rate of autoimmune hyperthyroidism.
Okay, so Turner syndrome covers the sexually infantile presentation with short stature. But what if you walk into the room, the patient has no breast development, no periods, but she is of perfectly normal or even tall stature?
If the stature is normal, but the reproductive system is entirely offline, the pathology has moved up the chain.
Up to the brain.
Yes. The ovaries might be perfectly intact, but they are waiting for a signal that never arrives. This is hypogonadotropic hypogonadism, and the classic disease model here is Kallmann syndrome.
I really love discussing Kallmann syndrome because it bridges neurology, embryology, and endocrinology in such a beautifully bizarre way.
It really does.
Like, you are interviewing this patient, you are trying to figure out why her brain isn't sending the GnRH signal, and you ask her an entirely unrelated question. You say, "Can you smell the coffee in the break room?" And she says, "No, I've never been able to smell anything." Boom. You have your diagnosis.
An animation of a fetal brain. A glowing cluster of neurons starts in the nasal region, olfactory placode, and slowly crawls up a nerve pathway toward the center of the brain, hypothalamus, illustrating the embryonic migration.
It is one of the most elegant clinical correlations in all of medicine. In Kallmann syndrome, the fundamental issue is a failure of embryological migration.
So they get lost along the way.
Exactly. During fetal development, the specific neurons that are destined to secrete GnRH do not actually originate in the brain. They originate outside the brain in the olfactory placode, which is the embryonic tissue that eventually becomes the nose.
That is so weird to think about.
Normally, as the fetus grows, these GnRH neurons physically crawl along the olfactory nerves, migrating all the way up into the hypothalamus to take their rightful place at the starting line of our relay race.
But in Kallmann syndrome, there is a mutation, I think it's often in the KAL1 gene, that prevents the synthesis of the protein required to build those microscopic tracts.
Yes. So the neurons get lost. They never make it to the hypothalamus.
So the brain has no GnRH. The starting gun never fires.
Without GnRH, the pituitary never makes FSH or LH. Without FSH and LH, the perfectly healthy ovaries just stay asleep forever. No estrogen, no breast development.
Unbelievable.
And because the olfactory nerves themselves are also malformed or absent, The patient presents with anosmia, a complete inability to smell, or hyposmia.
Our texts also note that common patients can present with midline facial defects like a cleft palate or optic issues like color blindness and optic atrophy. But the hallmark triad is delayed puberty, normal stature, and the lack of smell.
Right.
All right, that thoroughly covers group 1, the estrogen is missing. Let's move to group 2, the masculinized presentation.
This is a very different clinical picture.
Yeah, you walk into the exam room and the patient has primary amenorrhea, but instead of being infantile, she shows profound signs of virilization.
We are talking about a deep voice, severe acne, hirsutism, which is excess facial and body hair, and potentially ambiguous or enlarged external genitalia.
This means the patient is being exposed to massive amounts of androgens. And the heavy hitter in this category is congenital adrenal hyperplasia, or CAH.
CAH is a masterclass in enzymatic pathways. According to our texts, 95% of CAH cases are driven by a deficiency in a specific enzyme, 21-hydroxylase.
And this is an autosomal recessive condition, right?
Yes, it is.
To understand why a broken enzyme stops a period and causes virilization, you really have to look at the adrenal gland. The adrenal cortex manufactures 3 main types of steroid hormones from a common precursor, cholesterol.
Right. It makes mineralocorticoids like aldosterone, which regulates salt. It makes glucocorticoids like cortisol, which regulates sugar and stress. And it makes sex steroids like androgens.
I always remember the adrenal cortex layers as salt, sugar, sex, the zona glomerulosa fasciculata, and reticularis. So the adrenal gland brings in cholesterol and runs it down an assembly line.
But to get to the salt and sugar end products, the assembly line requires that 21-hydroxylase enzyme.
So if that enzyme is missing, what happens?
A factory assembly line. Cholesterol comes in. The pathways for aldosterone and cortisol have giant red X's over the 21-hydroxylase machine. All the conveyor belts suddenly reroute and dump the raw materials into the third pathway labeled androgens, causing a massive overflow.
The assembly line completely jams at the aldosterone and cortisol pathways. The brain realizes cortisol levels are dangerously low, so the pituitary secretes massive amounts of ACTH to whip the adrenal gland into working harder.
The brain is basically yelling, "Make more cortisol!"
Exactly. The adrenal gland hypertrophies, that's the hyperplasia in CAH, and brings in even more cholesterol. But the 21-hydroxylase road is still totally blocked.
So where does all that precursor material go?
All of these precursor hormones, massive quantities of them, are shunted down the only pathway left open, which is the androgen pathway.
Oh, wow. So you have a genetically XX female fetus. She has normal ovaries and normal Müllerian structures, meaning she has a uterus and fallopian tubes, because she doesn't possess the Y chromosome required to make anti-Müllerian hormone. Her internal female plumbing is perfectly intact. But because her adrenal glands are pumping out industrial levels of testosterone like androgens while she is still developing in the womb, her external genitalia become masculinized.
That is the virilization component. But we must emphasize that the classic form of 21-hydroxylase deficiency is an absolute medical emergency in infancy.
Right, long before amenorrhea is even a concern.
Yes. Because the adrenal gland cannot make aldosterone, the infant cannot retain sodium in the kidneys. They suffer from profound salt wasting.
What does that look like clinically?
The clinical presentation is an infant who is lethargic, vomiting continuously, profoundly dehydrated, and hypotensive. Their lab values will show severe hyponatremia, low sodium, and hyperkalemia, high potassium.
And if that enzymatic block is not bypassed with lifelong glucocorticoid and mineralocorticoid replacement therapy, it is fatal.
It is.
Now, there are non-classic or late-onset forms of CAH where the enzyme is only partially broken, right?
Yes, and those patients might just present at puberty with amenorrhea and severe acne mimicking polycystic ovary syndrome.
We also have to briefly mention the ultra-rare causes in this masculinized group, like true hermaphroditism, where the patient is an XXXY mosaic possessing both ovarian and testicular tissue. Or a patient who has a virilizing androgen-secreting tumor on their ovary or adrenal gland.
But CAH is absolutely the one you will be tested on.
Which brings us to the final and perhaps most anatomically fascinating category of primary amenorrhea. Group 3, the normally feminized patient.
This is the patient who walks in, she's a teenager. She has beautiful, perfectly normal breast development. Her body fat distribution is normal. She has axillary and pubic hair.
So the hormonal relays are firing perfectly.
Yes. The hypothalamus is pulsing. The pituitary is signaling. The ovaries are churning out estrogen and progesterone. The engine is purring.
But there is no period. Why?
Right.
Because the door is locked. This is almost exclusively an anatomical roadblock, and the major player here is Mullerian agenesis, also known as Mayer-Rokitansky-Kusterhauser, or MRKH syndrome.
Right. In embryology, the female reproductive tract develops from a pair of tubes called the Mullerian ducts, or the paramesomorphic ducts.
And what do those ducts become?
These ducts eventually fuse to form the upper two-thirds of the vagina, the cervix, the uterus, and the fallopian tubes. In Mullerian agenesis, these ducts simply fail to develop.
So the patient is born without a uterus.
Yes, without a uterus and with vaginal agenesis, meaning only a shallow vaginal dimple is present.
The critical thing to understand here is why she still has normal breasts.
That's a great point.
The ovaries do not develop from the Mullerian ducts. The ovaries developed entirely independently from a different embryonic structure called the genital ridge, so her ovaries are entirely unaffected.
Exactly. They produce perfectly normal female hormones, triggering flawless secondary sexual development. But because she lacks a uterus, she obviously has nowhere to shed an endometrial lining.
No uterus, no period.
Right. When you do an ultrasound on these patients, the ovaries are visible and normal, but the uterus is simply absent.
There are other things to look out for with Mullerian agenesis, right?
Yes. It is also critical to note that the urinary system develops in close proximity to the Mullerian ducts. Consequently, about a third of patients with Mullerian agenesis will also have significant renal anomalies, like a missing kidney or an ectopic kidney. So a renal ultrasound is absolutely mandatory.
Now, contrast Mullerian agenesis with the clinical vignette we opened the show with, the imperforate hymen.
Oh, right, the hematocolpos.
Yeah. In the case of an imperforate hymen or a transverse vaginal septum, the Mullerian ducts formed perfectly. She has a beautiful uterus, fallopian tubes, and upper vagina. Her hormone cycle, the lining builds up, and every 28 days, it sheds. She is menstruating.
But the distal end of the vagina is blocked by a rigid sheet of tissue.
Exactly. The blood pools. Month after month, it backs up into the vagina, creating a hematocolpos, and can even back up into the uterus, creating a hematometra.
The clinical presentation is unmistakable. This patient doesn't just have an absent period. She presents with intense cyclical pelvic pain that mimics a menstrual cycle but yields no blood.
And on physical exam, particularly if she presents to the ED in pain, you will often observe a bulging bluish membrane at the vaginal introitus.
And the treatment is purely surgical, right?
Yeah, a simple, crucial incision to open the hymen, release the trapped blood, and restore the outflow tract.
Immediate relief.
Before we leave primary amenorrhea, we have to talk about the great masquerader, a condition that looks like Mullerian agenesis from the outside but is genetically entirely different. Androgen insensitivity syndrome, or AIS.
A split screen comparing Mullerian agenesis, XX, uterus absent, ovaries present, and androgen insensitivity syndrome, XY, uterus absent, testes present but hidden.
AIS is a profound receptor-level failure. These patients are genetically male. They have a 46XY karyotype.
Wow, okay.
Because they possess a Y chromosome, their embryonic gonads differentiate into testes. These tests operate exactly as they should. They produce massive amounts of testosterone, and they produce anti-Mullerian hormone.
And the anti-Mullerian hormone does its job perfectly, right?
It does.
Yeah.
It actively destroys the Mullerian ducts, ensuring the fetus does not develop a uterus or fallopian tubes.
But here's the massive plot twist. The patient has a genetic mutation that renders every single androgen receptor in their body completely broken.
Completely broken.
So the testes are pumping out oceans of testosterone, trying to build male external genitalia, trying to deepen the voice, trying to grow facial hair, but the body is completely deaf to it. It's a broadcaster without a radio receiver.
That's exactly it. Consequently, the default pathway for external genital development is female. The infant is born looking entirely female externally and is raised as a girl.
And what happens when she reaches puberty?
Well, the testes, which are usually hidden internally in the abdomen or the inguinal canals, ramp up testosterone production. Because the body cannot use this testosterone, an enzyme in the peripheral fat tissue called aromatase converts all that excess testosterone into estrogen.
And that peripheral estrogen conversion triggers beautiful, normal breast development. So she looks like a perfectly normally feminized girl.
All right.
But she comes to you because she has never had a period. You do an ultrasound, and just like Mullerian agenesis, there is no uterus. So how do you tell them apart?
You look at the axillary and cubic hair. In Mullerian agenesis, the patient has normal female androgens from her adrenal glands and normal receptors, so she will have normal pubic hair.
And in AIs?
In AIs, because the androgen receptors are globally defunct, the patient will have very sparse or completely absent pubic and axillary hair. To confirm, you order a karyotype.
Okay, we've covered an insane amount of ground. To synthesize all of this for the medical student preparing for board exams, we utilize a 2x2 grid.
A sharp medical grid appears. The x-axis reads breasts, estrogen, present or absent. The y-axis reads uterus, anatomy, present or absent. The boxes fill in as the host speaks.
Picture a grid in your mind. On the bottom axis, draw a line for breast development. Present or absent? This tells you if the body makes estrogen. Up the side, draw a line for the presence of a uterus. Present or absent? This tells you if the anatomy is intact.
If breasts are present and the uterus is present, but she has primary amenorrhea, the engine is running and the room is built, you are looking for a locked door, an outflow tract obstruction like an imperforate hymen.
Got it.
If breasts are present but the uterus is absent, the body makes estrogen but lacks the anatomy. That is either Mullerian-agenesis XX or androgen insensitivity syndrome XY.
And if breasts are absent but the uterus is present?
Then the anatomy is fine, but the estrogen is missing. You are dealing with gonadal failure like Turner syndrome or central failure like Kuhlmann syndrome.
And it is exceptionally rare to have absent breasts and an absent uterus, but that would indicate a severe combined enzymatic or genetic defect.
Exactly.
It's just so elegant when you map it out like that. It turns a massive list of diseases into a simple logic puzzle. So that concludes the primary amenorrhea landscape. Now let's shift gears
to secondary amenorrhea.
Right. What about the patient who has had perfectly normal periods, but then they just stop? The engine was running, the track was clear, but the race was suddenly canceled. This is secondary amenorrhea, defined strictly as cessation for greater than 6 months.
When dealing with secondary amenorrhea, there's an absolute golden rule that transcends all specialized endocrinology.
Tell me.
Before you order MRIs, before you analyze enzyme deficiencies, you must address the most common, fundamental cause of secondary amenorrhea in humans.
Pregnancy.
Always, always, always check a pregnancy test, even if the patient swears on a stack of Bibles that she has never been in the same room as a man. Check the beta-HCG.
Absolutely. Once we have entirely ruled out pregnancy, and assuming the patient is not going through natural menopause, we systematically break down the pathological causes of secondary amenorrhea by level, returning to our HPO axis relay race.
The HPO axis diagram returns. The relay track from hypothalamus to pituitary to ovaries to uterus is shown. A red warning light flashes at the hypothalamus.
Let's start at the top. Level 1, the hypothalamus. Okay, so if the hypothalamus stops releasing its pulsatile GnRH, the entire system shuts down in a domino effect.
Right. The specific condition here is functional hypothalamic amenorrhea. The sources point strongly to environmental and metabolic stressors.
Like what?
Severe eating disorders like anorexia nervosa and bulimia, profound psychological stress, and a strenuous high-level athletic training.
And this isn't just the body being fragile. This is an incredibly sophisticated evolutionary survival mechanism.
Exactly. It's about survival.
The brain has an energy sensor mediated by hormones like lectin from fat cells and cortisol from stress pathways. If a woman is starving or her body fat drops below a critical threshold due to running marathons every week, the brain performs a subconscious calculation.
It says we do not have the caloric reserves to sustain a 9-month pregnancy.
If we get pregnant now, the mother dies, the baby dies. So to preserve the life of the host, the hypothalamus actively silences the kisspeptin neurons, which in turn silences the GnRH pulses. The reproductive system is voluntarily shut off at the main breaker.
It is energy conservation in its purest form. And the treatment here isn't necessarily hormones. It is restoring the caloric deficit, reducing the stress, and regaining weight, at which point the hypothalamus will turn the metronome back on.
Now, what if the hypothalamus is pulsing, but the baton drops at level 2? The pituitary gland.
This is where we leave the realm of physiological stress and enter the realm of true pathology, tumors and vascular catastrophes.
Let's talk about the most common pituitary tumor causing amenorrhea, the prolactinoma.
A prolactinoma is a benign adenoma of the lactotroph cells in the anterior pituitary. These tumor cells blindly pump out massive quantities of prolactin, the hormone responsible for stimulating breast milk production.
Now, wait a minute. If prolactin is a hormone for making breast milk, it makes perfect sense that a patient with this tumor would have galactorrhea, inappropriate milk discharge from the nipples. But why does a milk hormone stop her periods? What is the molecular connection there? Is the body basically saying, hey, we are currently feeding a baby, let's not start another pregnancy right now?
That is precisely the evolutionary logic. In nature, lactational amenorrhea prevents a woman from getting pregnant again while she is still nursing an infant, spacing out pregnancies to ensure survival.
Okay, that makes sense.
On a molecular level, high concentrations of prolactin travel from the pituitary up into the hypothalamus and actively suppress the release of GnRH. The prolactin physically acts like a brake on the GnRH metronome.
And without GnRH, there is no FSH or LH, the ovaries go to sleep and the periods stop.
Exactly.
And as a clinician, you have to be vigilant because a prolactinoma isn't just an endocrine problem, it's a space-occupying mass in the brain.
Yes, the anatomy is very important here.
The pituitary sits right in the sella turcica, a tiny, bony saddle. If the tumor grows larger than a centimeter, a macroadenoma, it bursts out of that saddle and presses directly on the optic chiasm, which sits right above it.
And the optic chiasm is where the nerve fibers responsible for your peripheral vision cross over.
So what happens to the patient's vision?
When the tumor compresses those specific crossing fibers, the patient develops a very specific visual field defect.
Right.
Bitemporal hemianopsia. They literally lose their peripheral vision on both sides. They can only see straight ahead, like they're wearing blinders.
So an unexplained loss of peripheral vision combined with amenorrhea and galactorrhea is a prolactinoma until proven otherwise.
Right.
The sources also mention another pituitary tumor, the craniopharyngioma. This is totally different from an adenoma. It's derived from leftover embryonic tissue, specifically remnants of Rothke's pouch. And the classic radiologic clue you will be tested on is that on an X-ray or CT scan, you can actually see little flecks of calcification in the suprasellar region.
Very high yield fact.
But as fascinating as tumors are, I want to talk about the vascular catastrophe at the pituitary level, Sheehan syndrome. This is one of the most tragic and conceptually vital pathophysiologies in all of endocrinology.
An animation of the anterior pituitary gland during pregnancy. It swells and doubles in size, glowing red with increased blood demand. Suddenly, the blood supply line pinches off, and the gland turns a necrotic ashen gray.
Sheehan syndrome is the ischemic necrosis, or tissue death, of the anterior pituitary gland. To understand it, we must look at what happens to the pituitary during a normal pregnancy.
It gets bigger, right?
Much bigger. To meet the massive hormonal demands of gestation, specifically the need for prolactin to prepare for breastfeeding, the lactotroph cells in the pituitary undergo intense hyperplasia. The gland literally doubles in size.
But there's a flaw in that design.
A fatal anatomical flaw. While the tissue mass doubles, the vascular supply, the portal venous system feeding the gland does not increase proportionally.
It's like building a massive expansion on a factory but not upgrading the power lines. The pituitary is operating on the absolute brink of ischemia for 9 months. It is incredibly vulnerable to any drop in blood pressure.
Precisely. Now imagine the patient goes into labor. The delivery is complicated, and she suffers a massive postpartum hemorrhage.
She loses liters of blood.
She goes into hypovolemic shock. Systemic blood pressure plummets. In a desperate bid to save the brain and heart, the body clamps down peripheral blood vessels.
And the pituitary.
The already starving enlarged pituitary gland suffers catastrophic ischemia. The oxygen supply is cut off, and the cells of the anterior pituitary simply die.
The destruction is devastating because the anterior pituitary doesn't just make one hormone, it's the master conductor. It makes prolactin, FSH, LH, TSH, and ACTH. When it dies, the entire endocrine orchestra goes silent.
Yes, the immediate clinical sign, literally in the days following the hemorrhage, is agalactorrhea.
No milk.
Right, the mother is desperately trying to nurse her newborn, but her body produces absolutely no breast milk because the lactotrophs are dead.
And then the cascade of systemic failures becomes apparent. She develops secondary amenorrhea because she has no FSH or LH to restart her ovarian cycle. She develops profound fatigue, weight gain, and cold intolerance because she has no TSH to stimulate her thyroid. Secondary hypothyroidism.
And most dangerously, she develops secondary adrenal insufficiency because she lacks ACTH to stimulate cortisol production, leaving her unable to mount any physiologic response to stress, which can lead to a fatal hypertensive crisis.
Sheehan syndrome is a stark reminder that in medicine, the history is everything. A patient coming in with amenorrhea and fatigue who tells you she almost bled to death during childbirth 3 years ago, you already have the diagnosis before you even draw the blood.
Absolutely.
So we've covered the hypothalamus and the pituitary. Now we move down to level 3, the ovarian roadblocks. The runner gets the baton, the FSH and LH arrive, but the ovaries are broken. The undisputed heavyweight champion of ovarian secondary amenorrhea is polycystic ovary syndrome, or PCOS.
The relay track focuses on the ovary. Instead of one smooth follicle growing, the ovary is crowded with dozens of small, half-grown follicles, trapped in a chaotic, static state.
PCOS is the most common cause of anovulatory infertility in the developed world. It is an incredibly complex metabolic and endocrine disorder.
And the hormonal profile for PCOS is highly specific and heavily tested, right?
Very much so. It is characterized by an inversion of the normal gonadotropin ratio. Normally, in the early phase of the menstrual cycle, FSH is higher than LH.
But in PCOS, that ratio is flipped.
You have chronically elevated luteinizing hormone levels, creating an LH to FSH ratio of 2.1 or even 3.1. You also have elevated androgens like testosterone and androstenedione and profound underlying insulin resistance.
Okay, let's break that down mechanically. Why does the LH to FSH ratio flip? If the ovaries are full of follicles, which is what polycystic implies, shouldn't estrogen be doing something? It feels like the system is jammed.
Jammed is the exact right word. It is a state of static hum rather than a dynamic waves. Let's follow the pathology.
Okay, walk me through it.
The fundamental driver in many patients is insulin resistance. The pancreas pumps out excess insulin to manage blood sugar. That excess insulin acts synergistically with the inappropriately high LH to hyperstimulate the SE cells within the ovary.
And the ACA cells make the male hormones, right?
Yes, they are responsible for manufacturing androgens. So the ovaries pump out massive amounts of testosterone and androstenedione, causing the classic clinical symptoms of severe acne, male pattern hair loss, and hirsutism.
But those androgens don't just stay in the ovary. They enter the bloodstream and travel to the patient's peripheral fat cells. Inside the adipose tissue, the aromatase enzyme converts those raw androgens into a weak estrogen called estrone.
Exactly. This creates a steady, chronic baseline level of estrogen in the blood.
And that chronic, steady estrone goes up to the pituitary gland and applies constant negative feedback to FSH production. So FSH stays relatively low.
Meanwhile, the pituitary becomes sensitized to GnRH pulses and dumps excess LH. Because FSH is suppressed, the ovary never gets the massive FSH wave required to select and mature a single dominant follicle.
So what happens to all those follicles?
Instead, dozens of follicles are partially stimulated, they grow slightly, and then they stall out. They arrest.
And when you do an ultrasound, you see all those stalled, arrested follicles lining the periphery of the ovary like a string of pearls. They aren't actually cysts, they are failed follicles.
Right. Because none of them ever mature, the massive estrogen spike never happens. Because the estrogen spike never happens, the mid-cycle LH surge never happens. Therefore, ovulation never occurs.
And no ovulation means no corpus luteum, which means absolutely no progesterone is produced.
This brings us to a critical, potentially life-saving point of clinical counseling for PCOS patients. Because these patients are anovulatory, they are living in a state of unopposed estrogen.
Unopposed estrogen is dangerous.
Very dangerous. Their peripheral fat is constantly making estrone, which constantly stimulates the endometrial lining of the uterus to grow, thicken, and proliferate. But because they lack progesterone, the gardener that stabilizes and eventually sheds the lining, the endometrium just keeps growing unchecked.
And that unopposed estrogen significantly increases their risk for endometrial hyperplasia and eventually aggressive endometrial cancer.
Yes, you cannot just let a PCOS patient go years without a period. You must artificially protect their uterus, usually by prescribing cyclic oral contraceptive pills or a progestin-releasing IUD to force the lining to shed and prevent that malignant transformation.
Now, on the opposite end of the ovarian spectrum from PCOS, we have premature ovarian failure, or POF. This is also called premature ovarian insufficiency.
POS is, by definition, the onset of menopause before the age of 40. Unlike PCOS, where the ovaries are full of stalled follicles, in POF, the ovaries have literally run out of functional follicles.
How does that happen so early?
This can happen due to autoimmune destruction, genetic anomalies like Fragile X premutation, or iatrogenic causes like aggressive chemotherapy or radiation therapy that destroyed the ovarian reserve.
Going back to our relay race, the pituitary runner is standing on the track, screaming at the top of their lungs, waving the baton, but the ovarian runner has literally packed up and gone home.
That's exactly it.
Because there are no follicles left to produce estrogen, the estrogen levels plummet to near zero. Without estrogen, there is no negative feedback on the brain. The brain panics. The pituitary produces massive, sky-high levels of FSH and LH, desperately trying to whip the dead ovaries into action.
Clinically, these patients suffer from severe, acute menopausal symptoms. It is not just the amenorrhea. They experience profound vasomotor instability of debilitating hot flashes and night sweats, along with vaginal atrophy causing painful intercourse.
And a rapid decrease in bone mineral density leading to early osteoporosis.
Yes, they require significant hormone replacement therapy, not just for symptom relief, but to protect their bones and cardiovascular system until they reach the natural age of menopause.
Okay, we've made it to the final runner. The hypothalamus is pulsing, the pituitary is signaling, the ovaries are ovulating, the hormones are cycling perfectly, but the patient still has secondary amenorrhea. We have reached level 4, uterine causes, specifically Asherman syndrome.
The relay baton successfully reaches the final runner, the uterus, but the runner is bound in thick, white, fibrous scar tissue and cannot move.
Asherman syndrome is an acquired anatomical roadblock. It is characterized by the presence of dense intrauterine adhesions, or synechia.
Meaning the uterus is glued shut.
Essentially, yes. The front and back walls of the uterus have become glued together by thick scar tissue.
How does that happen? The uterus is normally incredibly resilient. I mean, it sheds its lining and regenerates entirely every month. How do you destroy it?
You have to look at the microscopic layers of the endometrium. The endometrium has 2 layers. The functionalis layer, which is the part that builds up and sheds every month, and the basalis layer, which is the deep stem cell reservoir that regenerates the functionalis.
So you have to destroy the basalis layer.
Exactly. Asherman syndrome occurs when there is severe mechanical trauma that strips away the endometrium so deeply that it completely destroys that regenerative basalis layer.
The classic clinical history you will see on a board question or on the wards is a patient who recently underwent a dilation and curettage, a D&C.
Yes. This is a surgical procedure where the inside of the uterus is scraped, typically performed after a miscarriage, to remove retained products of conception or for a termination of pregnancy.
And if the curettage is too aggressive, or if the procedure is complicated by a severe uterine infection like endometritis, the basalis layer is eradicated.
Without the basalis layer, the endometrium simply cannot regrow. As the raw, denuded walls of the uterus attempt to heal, they scar to each other, obliterating the uterine cavity.
Even though the HPO axis is functioning flawlessly, the ovaries are making estrogen and progesterone. The patient might even experience premenstrual symptoms like breast tenderness and bloating. But there is no target tissue left to respond to the hormones, and therefore absolutely no bleeding.
Right. And the gold standard for diagnosing and treating Asherman's is a hysteroscopy, where a camera is inserted into the uterus, allowing direct visualization, and a surgeon uses microscissors to carefully cut away the fibrous bands and restore the uterine cavity.
Unbelievable. We've covered everything from missing chromosomes to ischemic brain necrosis to scarred uteri. We've mapped the physiology, and we've walked through the massive landscape of primary and secondary etiologies. But knowledge is useless if you don't know how to deploy it.
Right. It has to be practical.
Let's put on our white coats. Let's make this clinical. How do we actually work up a patient presenting with amenorrhea step by step so you can memorize the diagnostic approach for your rounds?
A massive glowing blueprint appears. A 3-step checklist is stamped on the screen. 1, beta-HCG. 2, ultrasound. 3, hormone panel. FSH, LH, prolactin, estradiol, TSH.
The clinical workup must be disciplined, sequential, and evidence-based. Step 1, as we have heavily emphasized, is to definitively rule out pregnancy. You must order a spot urinary pregnancy test or quantitative serum beta-HCG.
You never assume a patient cannot be pregnant based solely on her reported history.
Never. Once the pregnancy test is negative, step 2 is imaging. Our sources specifically mandate a pelvic ultrasound. But there is a massive clinical nuance here regarding the type of ultrasound, specifically for primary amenorrhea.
This is a huge point. If you have a young virginal teenager presenting with primary amenorrhea, you explicitly do not perform a transvaginal ultrasound or a deep digital pelvic exam.
That is a critical error in clinical judgment. The transvaginal probe is inappropriate and traumatic for a virginal pediatric or adolescent patient.
So what do you do instead?
Instead, you perform a transabdominal pelvic ultrasound. The patient must have a full bladder to create an acoustic window. The goal of this imaging is purely structural. You are looking to confirm the presence, size, and normal development of the uterus, the ovaries, and the vaginal canal.
And this step immediately rules in or rules out the profound anatomical defects like mullary anagenesis or an imperforate hymen. Okay, pregnancy is ruled out, anatomy is visualized. Step 3 is the biological deep dive, the hormone labs. Our grounding texts define a very specific targeted panel you need to order to interrogate the HPO axis.
You order FSH and LH to check the pituitary, estradiol to check the ovaries, and prolactin to rule out a prolactinoma.
Additionally, checking TSH, thyroid-stimulating hormone, is absolutely vital.
Yes, the thyroid is intimately connected to the reproductive axis. Profound hypothyroidism can alter the metabolism of estrogen and increase TRH from the hypothalamus.
And elevated TRH can directly stimulate the pituitary to release excess prolactin, causing amenorrhea. So a simple underactive thyroid can entirely stall the reproductive cycle.
Precisely.
Now, let me stop you right there and play devil's advocate for the medical students listening. Almost every older textbook and a lot of attending physicians on the wards will talk about the progestin challenge test. The idea is that you give a patient a course of oral progestin pills for a week and then stop them. If she bleeds, it proves she has adequate estrogen in an open outflow tract. If she doesn't bleed, her estrogen is shot or her uterus is scarred. Where does that fit into our diagnostic algorithm here?
That is an excellent practical question, and it is a nuance we must clarify. While the progestin challenge test is a classic tool historically used to evaluate secondary amenorrhea, our specific clinical guidelines and the core text data provided for this deep dive do not outline it as the primary required step for diagnosis.
Really? So we skip it?
Our source material focuses on the direct, quantifiable data provided by the hormone assays. We rely on drawing the actual blood levels of FSH, LH, and estradiol.
Right, because why wait 2 weeks to see if she bleeds when you can just look at her actual estradiol level on a blood test today?
Exactly. Relying on the serum hormone assays gives you direct, immediate, and specific data on exactly which level of the HPO axis has failed without relying on the secondary biological response of a withdrawal bleed. So, strictly following the data we are grounded in today, your primary diagnostic tools are the beta-HCG, the ultrasound, and the specific hormone panel.
Clinical note. While historically common, the progestin challenge test is omitted here as it is not specified in the primary diagnostic guidelines of the current source data favoring direct serum hormone assays.
I think that's incredibly clarifying. Stick to the objective lab data. Let's do a rapid recap of the absolute highest yield points we've covered in this hour-long journey.
Let's do it.
First, the diagnostic definition. Primary is never menstruating. Secondary is a cessation of greater than 6 months in a patient who previously menstruated.
Second, for primary amenorrhea, rely on that 2x2 grid in your mind. Compare breast development to the presence of a uterus. Turner syndrome has no breasts and high FSH. Mullerian agenesis has normal breasts but no uterus.
Third, memorize the flipped LH to FSH ratio in PCOS, often 2.1 or 3.1, and never forget to counsel those patients on the severe risk of endometrial cancer due to unopposed estrogen.
And finally, remember the tragic pathophysiology of Sheehan syndrome, a massive postpartum hemorrhage leading to profound hypovolemic shock, pituitary ischemia, necrosis, and complete panhypopituitarism.
If we step back and connect all of this to the bigger picture of human biology, it becomes undeniably clear that amenorrhea is rarely a disease in isolation.
It is an evolutionary alarm bell. It is the human body prioritizing its own survival over the immense metabolic cost of reproduction.
Whether that shutdown is triggered by the systemic starvation seen in anorexia, the vascular collapse of Sheehan syndrome, the structural dead end of an imperforate hymen, or the genetic roadblocks of Turner and Kallman syndromes, the cessation of the menstrual cycle is the body loudly communicating that the conditions for sustaining new life are fundamentally compromised.
It really is an incredible system when you look at it from that perspective.
Next time you are on the wards and you are looking at a patient's menstrual chart, don't just see dates and missing check marks. Look past the paper. See the incredible, delicate, microscopic relay race happening behind the scenes.
Think about the neurons crawling up the fetal olfactory nerve. Think about the dominant follicle fighting for survival.
Think about the baton passes between the brain and the pelvis. Keep questioning those mechanisms. Keep pushing for the why behind the what. And you will never just be memorizing medicine. You will be understanding it. Keep connecting the dots, and we'll see you on the next deep dive.